Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Saramelli, and I oversee our Grand Round Series for the department. This year we changed our Grand Round Series to a webinar format, and we've had presentations covering multiple different areas. The other thing we've done is we've started a feedback and evaluation form, and I'd encourage you to consider filling out the evaluation after today's presentation. That is helpful information for me to review when thinking about planning our series and afterwards with corresponding with presenters. Also, for today, you don't have to save your comments and questions to the end. It would be okay and actually encouraged to type in questions, comments about things that come up during the presentation. If comments come in, I can help to facilitate a discussion with today's presenter, Dr. Spotswood. And Dr. Spotswood could say more about that, but I will be monitoring that closely throughout the presentation. And now to today's presenter. Today for Grand Rounds, the presenter's name is Dr. Margaret Spotswood. Dr. Spotswood is a psychiatrist and works at the Community Health Centers of Burlington, which is a federally qualified health center in Vermont, and has an appointment as well as a clinical assistant professor at the University of Vermont. Dr. Spotswood's work has included seeing patients of all ages in primary care, works also on a statewide consultation program to children throughout Vermont, and works in collaborative care in an obstetrics and gynecology setting. Additionally, Dr. Spotswood runs a continuous education program for primary care clinicians in the FQHC. Really a range of work encompassing many of the aspects of outpatient CL psychiatry. A little bit of background about Dr. Spotswood. Dr. Spotswood completed medical school at the University of Vermont, followed by psychiatry residency and a child and adolescent psychiatry fellowship at the Cambridge Health Alliance and Harvard Medical School. Additionally, Dr. Spotswood completed a master's in public health program at Harvard as well. And since completing training, Dr. Spotswood has maintained a focus on scholarly work while continuing to work in the FQHC, which includes developing interest and expertise in primary care assessment and treatment of post-traumatic stress disorder and attention deficit hyperactivity disorder, the latter of which Dr. Spotswood will talk about today. So I'll stop for now and turn it over to Dr. Spotswood.
Great. Thank you so much. Let me just share my screen here. All right, you can see that.
Yes.
Great. All right, so thanks again so much for having me. I'm really excited to talk to you all today. And today's topic will be adult ADHD in primary care, thinking about a systematic approach for the integrated team. So I'll review my practice and go over the epidemiology of adult ADHD, review the DSM and also some marketing, and talk about the clinical presentation that we see, as well as the clinical diagnosis. We'll hinge our talk on the treatment flow diagram that we have in a recent paper, and we can talk about management, and throughout we'll have some composite cases and discussion. So that will be kind of a good time if anyone has questions as we go through the presentation today. So where do I work? I work at the Community Health Centers of Burlington in Vermont. We see about 30,000 primary care patients over 8 sites, and it is an FQHC, which means that we have more funding for kind of a more robust mental health department. To give you a sense of what that is, our whole department, the psychiatrists and the psychiatric nurse practitioners, saw about 3,000 psychiatric intakes over the last 2 years. And so you can see, we see about 10% of the visits. And we are co-located, unfortunately, so we're working on it, but currently we're co-located, which just means that I get, exposure to kind of all the psychiatric questions rather than working with a care coordinator. We also have therapy and social work available in our community health center. And to give you just a sense of the scope, I did about 400 intakes during my first year of practice. And again, if we were to move toward that care coordinator model, it would be maybe 400 consultations. So I do have familiarity with the collaborative care model. As Joe mentioned, I did my training at the Cambridge Health Alliance, and I was there at a really exciting time for them when this care coordinator, collaborative care, population-based care model was rolled out throughout the Cambridge Health Alliance. So I got to actually kind of see that in action, and again, hoping that we can do that in our community health center. So really, what can psychiatrists do when patients are referred from primary care to a psychiatric clinic, or a question is brought up with the care coordinator for an adult ADHD evaluation? When is it appropriate to send these patients back to primary care versus ongoing management and specialty care? So, again, seeing so many patients, a lot of things come up over and over again. So some of that is like insomnia or PTSD, and adult ADHD is one of those topics. And so I was able to write a paper with some of the folks that I trained with on this topic. And so that's the basis of this talk today. We'll start with a composite case study. You're working with a care coordinator who presents a Caucasian male in his mid-40s. He's married. He has many children, 2 of whom have the diagnosis of ADHD. And he's coming in with a complaint of trouble concentrating at work. He works as an IT manager, and he specifically has trouble switching between tasks or completing tasks. So if someone interrupts him, he'll kind of go off in that direction and then have trouble coming back to what he was doing. He also mentions marriage difficulties. His PHQ is 10 and GAD-7 is a 4. And his main goal in engaging in treatment is to make things easier. At least that's how he reported it to his primary care provider. So where and how are we going to provide care to this man, and what are the next steps? And again, we'll return to this case at the end, but if you can just think about him and the other cases that I bring up throughout the presentation, I think it'll make the content a bit easier to digest. So let's start on epidemiology. These are the numbers we used in our paper, and they're from the National Comorbidity Survey replication in 2005 and 2006 with Kessler as the primary author, first author. The prevalence of adult ADHD is 4.4%, at least it was in 2005. The lifetime prevalence is 8.1%, and most of these people are male and white. And then we can see, we'll kind of walk through how in 2013, the DSM IV kind of embraced the adult diagnosis a bit more, keeping in mind that a good portion of folks kind of creating these diagnoses together also work in industry or have pharmaceutical ties. So adult ADHD, what is it? It's a pattern of inattention and or hyperactivity impulsivity that interferes with functioning. Adults need 5 inattentive or 5 hyperactive impulsive symptoms. They need several prior to age 12 and several in 2 or more settings that cause severe impairment. This can't be explained by another disorder, and that's really key for how we approach this diagnosis. 5 inattentive could include failing to give close attention to details, making careless mistakes, problems not listening, not following through, problems organizing, losing things, being forgetful, being easily distracted, trouble with sustained mental effort. I don't know if you've had a poor night's sleep the night before, but I certainly have, and could probably give myself at least maybe 4 of these after a poor night's sleep. So let's see. So then we move on to the 5 hyperactive or impulsive. And those could include for an adult feeling restless, talking a lot, blurting out an answer, trouble waiting turns, maybe interrupting or intruding on others. And in terms of key changes between the DSM IV and the DSM V, in the DSM IV, adult ADHD was housed as a disorder usually diagnosed in infancy, childhood, and adolescence. 6 symptoms were required for adults and several prior to age 7. There was also a specifier saying in partial remission meant that especially adults or adolescents who no longer met full criteria. So there's this kind of sense that a patient would move from having it in childhood to having it in adulthood, whether or not it was in partial remission. In the DSM IV, it's considered a neurodevelopmental disorder. So other neurodevelopmental disorders include intellectual disability, communication disorders, autism spectrum disorders, and schizophrenia. And I came across some literature noting that there's quite a lot of overlap between the symptoms of those diseases. And so that might need to be kind of looked at further in terms of, do they belong together? Are they separate? Or, is there a lot of overlap? 5 symptoms are required for adult ADHD in DSM-5, several prior to age 12. So you can see that kind of loosening a bit. And specific examples were provided both for children and for adults in the new DSM. And some examples for adults included being distracted by unrelated thoughts or feeling restless. And here's just a quick Google search of some of the folks who were on the committee for ADHD. And so I just searched everyone's name and also conflict of interest. And again, this is not comprehensive, but just an example. So I guess it begs the question kind of like whose needs are being met by this diagnosis? I don't want to forget that question while I'm going about my clinical work. And what do we see? We do see changing epidemiology as the diagnosis changed, or even before the diagnosis was changing. So there's a 344% increase in women being prescribed a stimulant medication between 2003 and 2015. And overall, you can see that amphetamine scripts increased 2.5 times from 2006 to 2016. And this data is directly from the DEA. They have something called the Automation of Reports and Consolidated Orders System for stimulants. And you can see they report it every year. You can see how the metric tons of amphetamine in particular changed from 7 metric tons in 2006 to 20 metric tons in 2016 being prescribed in the United States. There's also a lot of regional variation. This is a really interesting paper. There's a New York Times article in 2013 kind of paying attention to this. The FDA has cited every major ADHD drug, stimulants and non-stimulants for false and misleading advertising. And so what might that look like? And again, this is just kind of information that our patients are coming in with. You can see on the right that a kid with ADHD symptoms plus a medication might turn into a doctor. Or there was a quotation I came across in a paper by Moffitt saying, I didn't outgrow my ADHD. Did you, your ADHD, own it? So I was like, all right, I want to own it. I went to ownYourADHD.com to verify the quotation and was immediately redirected to a site called everydayhealth.com. And there was a general article about ADHD, and multiple times this article called, "Could you have adult ADHD? How to discuss it with your doctor?" just popped up several times. So I did click on that link as well. And it kind of walked me through what I should talk about with my doctor, including giving specific examples. And then it also cited, various different medications and strategies, but it did cite one medication over and over again. So I think that we can think about kind of the advertising as shifting from maybe direct advertising to thinking about how is the advertising getting into the internet essentially and getting to people. And you can see it changes. Again, from the New York Times, the prescriptions for adults are growing more quickly than for children, and that's from 2008 to 2012. And the source of this data is IMS Health, which is actually what the industry uses. So IMS Health provides data to government or the pharmaceutical companies to see, and their goal is to show the impact of pharmaceutical advertising. And I was looking for more recent data from them, but I think they merged with someone And so I wasn't able to find more recent data, but you can see the two different trajectories, both increasing, but adults increasing faster than kids. So in clinic, what might changing epidemiology look like for us? Like who's walking in the door here? One example might be an African-American woman in her mid-20s. She's single and she's new to individual therapy. She's seen her community therapist for 3 visits, and she's presenting to her primary care provider because her therapist suggested to ask your doctor for medicine for ADHD. Again, these are composite cases, but it's something I've heard many times. She's had no previous medications. She's an average student in college, works in an office, enjoys living with her 2 roommates. Her PHQ-9 is 11, but otherwise her psychiatric and medical screenings are fairly unremarkable. And so this is an example of kind of what new populations might be bringing up this diagnosis. And if anyone has ideas or thoughts at this point, you can shoot your questions over. And if not, we can again return to this case at the end of the talk. So I'll just give a few minutes, a few seconds in case someone has questions at this point.
Dr. Spotswood, while we wait for a potential question, I wonder, in circumstances like this, how often are you seeing this type of question even preceding a diagnosis?
Yes. Yeah, so I included it because it's not uncommon from my practice. I don't know how, and my colleagues as well. So I don't know how often people are coming across this question in Washington State, but it's pretty common, which is why I included it. And, I don't know what happened with the therapist. Like maybe the therapist gave the patient a screener, and we'll review the screening options a little bit later. But it seems like, it's on therapist radar in addition to being on patient's radar. All right.
Okay.
Great, thank you. All right, so patients aren't, reading the DSM and coming in with a checklist of exact symptoms, but they are complaining often about struggles attending to work, school, or home, trouble concentrating, not being able to organize. Incomplete projects is a big one that I hear about. And, having a hard time with school or work, problems with time management. Temper comes up in the Utah criteria specific to adult ADHD. And anxiety, and more often than not, they will say, since I was little. So I don't think people are kind of inventing these symptoms. And I think that it's certainly important to pay attention to them and see what we can do to treat them. What we do know about diagnosis, and I think this is a question in progress, we do know that about 90% of adult ADHD patients did not have ADHD in childhood. We also know that most child ADHD does not actually persist. I looked all over for an exact answer to that question, how much child ADHD does persist. In our paper, we used a prospective cohort paper, which found the number to be 17%. And then I found a really nice systematic review of longitudinal studies, which cited about 40 to 50%, but one of the points of that paper was that it really varied depending on how you defined adult ADHD. So I think like the take-home point is that defining adult ADHD is really important, and we don't have consensus yet on how to do that, at least in research studies. We also know that patient recall is inaccurate, and that about 50% of patients with adult ADHD also have comorbid psychiatric or substance use disorder, which can in and of itself lead to inattention. And things like, depression also has a component, a symptom of inattention. So I think that's something just to watch for. So when I'm wondering about how do I diagnose something, how do I diagnose adult ADHD, this seems a little bit challenging at this point. I love rating scales. For example, bipolar disorder, adult bipolar disorder has been, a question that comes up often in clinic. And I love using the city to say, okay, this is kind of the percent chance of this person having bipolar disorder. Let me put that together with the family history, with the patient's current symptoms, and then we can kind of move forward in terms of appropriate treatment for that patient. And there are many adult ADHD rating scales. So there's the Wender Utah rating scale, Connor's adult ADHD rating scale, the adult ADHD self-report scale, the ASRS, and then there's maybe even neuropsych testing might be helpful. So unfortunately, these just end up not being helpful because of the nature of the questions. They're essentially all positive when I ask them to patients. And so I was using the ASRS at the beginning of my practice, like 3 years ago, but it didn't end up being time effective because everyone was positive. In terms of neuropsychological testing, the best information I found on that was in the Nicholas paper from 2019, showing that a combined approach using self and informant symptom ratings and a positive family history of ADHD and a reaction time variability measure correctly classified about 87% of cases. So neuropsych testing used in conjunction with other clinical assessments might enhance prediction of adult ADHD diagnosis. So that's promising. But again, I'm working in kind of a high volume federally qualified health center, and essentially neuropsych testing for everyone raising this question is not available. It's not possible. The upshot is that if you do have a negative ASRS, you can be sure that it's negative. So if you do ever come across a negative one, there's a 98% negative predictive value. And I think there's a question, yeah.
Actually, yes, several questions have come in. One that's very timely, and if we might just address the other two. What is the gold standard for diagnosis then?
Right. I was trying to find I think it's kind of, I can review it, but it's essentially getting collateral from someone who knows the patient, ideally when they were a child as well. Using the ASRS is also, recommended, using a screening measure, and then patient self-report and just making sure, they're checking off those boxes. So that's my understanding.
Thank you. Another question, maybe related to one of the cases. Is if a young adult doing okay in school, high school, college, or college, not treated during that time, seems to be functioning okay. Does that sort of rule out ADHD? Like, what would you think? Like, functioning is okay.
Yeah, you have to have severe problems with functioning in order to have this diagnosis. So I think that that case is included in this talk because people whose functioning is what I would consider okay are coming in with this question.
Yep. Thank you.
Yeah.
This question touches on many things, so I'll try to summarize it as this individual works in primary care, and we often receive a question of, quote, ADHD diagnosis confirmation. Most were already receiving stimulants, and this person had the experience. It seemed like they were kind of set up to be the person to say no stimulant treatment. What is that your experience? What have you seen that? How do you manage that?
That's such a great question, because at the end, throughout the talk, I'm kind of talking about diagnosing and then treating. But the reality is that most people are coming into us already with a diagnosis, already on stimulants. And so I would kind of start from scratch and kind of go through this algorithm, this flow diagram that I'll present a little bit later in the talk. So,
okay.
Yeah.
An interested audience. Two more things.
It's a hot topic. We see a lot of patients with this. Yeah.
What about this comment? I might be functioning okay, but I could function better. Yeah.
Agreed. Yeah. Yes, that comment I see a lot in my work as well. And I think that's the question that, not with just this diagnosis, but with other diagnoses. So I think that, you know, if the treatment is a medication, the company selling the medication is going to want to kind of broadly apply the diagnosis so that more people will use the medication. And again, this is, I don't have a study to back this up, but that's kind of my clinical understanding. And so, you know, people are getting bombarded with advertisements saying that if you take this medication, you can become a doctor. And I guess that's more of a cultural question, you know, is like, or do we want to be complicit with that and put people who could be doing better on medications? Or are we going to say, you know, actually, we need people that function really well, not at a computer. And there might be some other options in terms of how you could be doing better. So again, that's, yeah, my clinical answer.
Yeah, thank you. I acknowledge those who have written in additional questions, which I will continue to track. I'm going to stop for now. Dr. Spotswood can continue, and we'll pick up with questions in a little bit.
Yeah, and maybe some of the questions will be answered as I kind of go through. So thank you so much for your engagement, especially in this format. So when I was training, I really enjoyed using this wonderful flow diagram from the University of Washington. And so I just wanted to acknowledge that you are probably pretty familiar with this diagram. And the flow diagram that we created has some similarities and a few differences kind of based on our reading of some of the risks. So again, we're getting to diagnosis. And first and foremost, you want to evaluate, does the patient have current inattentive or hyperactive symptoms, or do they kind of just perceive that they do? And again, this is self-report, so that's actually sometimes challenging. Do the symptoms lead to the severe impairment? And then moving on to exclude medical, psychiatric, and other causes of these symptoms. So this is what it looks like. Please don't try to read this very small writing, but just to give you a visual, this is what I'll be walking us through. So I'll walk through all the writing. And this is just kind of a one-page diagram that we wanted to make available to primary care providers that might not have access to collaborative care, but might want to kind of think through as we might in collaborative care, as well as, you know, it can also be used in collaborative care. So you'll see here, this is the treating co-occurring disorders and screening for co-occurring disorders section. And you all, I'm sure, are experts at what rating scales to use for these different disorders and first line or second line treatments for these disorders. Let's see. So I'll just pull out like PTSD. I love screening for that one because helping patients know that their symptoms aren't coming from nowhere and that therapy is the mainstay of treatment, and then using medications adjunctive. Insomnia, was so excited when we started having some really amazing social workers offer CBT for insomnia, like right in our clinic, and I get really good feedback. And oftentimes patients stop asking for other diagnoses or other medications once they kind of have a better sense of what's an appropriate amount of sleep and how to do it. And then psychosis, I would just kind of put up a red flag for primary care providers about psychosis that warrants a direct psychiatry consultation. And then substance use disorder, you know, continuing to screen and motivational interviewing and avoiding benzodiazepines if those are present. Screening and treating medical causes. So this is another, I think, benefit to collaborative care, because all of these things actually can be done, you know, screening and treating psychiatric causes and medical causes can be done very rapidly within the primary care environment. So getting a great sleep history, whether that's the care coordinator kind of circling back, or if it's the primary care provider getting that. Screening for and treating obstructive sleep apnea with a stop bang. I actually get stuck on this one if patients can't tolerate the mask or might not even get to an appointment for obstructive sleep apnea. Thyroid disease, obesity, iatrogenic. Unfortunately, you know, a lot of the medications that are used in primary care that we use do cause these symptoms. So antihistamines, anticholinergics, benzodiazepines, sleep aids, narcotics, muscle relaxers, anticonvulsants can all cause inattention. So again, I'd rather decrease the medication burden than add another medication, kind of masking a iatrogenic cause. Hormonal changes. Is the person perimenopausal? Does the person have a history of brain injury, stroke, vascular disease, or dementia? And substance use disorder, again, particularly marijuana, which is legal. So I talk to patients about, it's okay if you're using marijuana. I mean, legally it's okay. But, if we're going to have a conversation about adult ADHD, that, marijuana causes inattention. So again, you can kind of choose between continuing marijuana or stopping marijuana and maybe considering a medication for inattention if the inattention persists after you stop the marijuana. And I have actually had some people over the long term choose to stop the marijuana. And sometimes they have the symptoms continue and sometimes they don't. So here's a diagnosis composite example. A care coordinator presents a Caucasian female in her late 30s in early polysubstance recovery. She's taking buprenorphine, naloxone for 6 months. She has regular negative urine drug screens, and she's working as a cleaner. And she's presenting with a chief complaint to get back on my Adderall. So how might we evaluate her diagnosis in collaborative care? And again, I think that going back to, actually even here, does she currently have inattentive or hyperactive symptoms? Do the symptoms cause impairment? And then excluding other medical, psychiatric, or other causes of her symptoms. If maybe she was on, that medication, before she stopped using, and maybe she's not as impaired, but thinks of it as a medication she's taken for a long time. So again, this is a question. We'll come back to this example, unless there are other kind of relevant questions. So I'll keep moving on. So next in our flow diagram, we moved on to, inattention. Did it start prior to age 12 years or hyperactivity? And is there severe and current impairment in more than one domain? If those are yeses, then we move on to behavioral interventions. So sleep, CBTI, organizational skills training, productivity apps. I was looking for a review paper on those, and unless I missed one, that might be a need. But there are lots of lists on the internet. So I just tell people to kind of ask, what works for other providers around them when I'm talking to PCPs. ADHD support groups. And all of this, again, I think can come from the care coordinator, or if the person requires kind of a higher level of intervention, maybe the embedded therapist. And if neither of those are available, there's a site called ADHDcoaches.org, which is a clearinghouse for people who are trained as ADHD coaches, some of whom are able to bill depending on their credentials, and others are unable to bill, unfortunately, bill insurance companies. So psychoeducation and organizational planning, problem solving, this can come directly from the primary care provider, from the care coordinator, just helping people think about breaking large tasks into smaller tasks and not rushing. Are there things that are distracting the patient that they could change? Environmental strategies. Maybe we don't all need like literally 4, I have 4 screens in front of me. Maybe just 3 would do in today's world. Thinking about adaptive thinking and education about procrastination. I love the Ohio method, only handle it once. The mail comes in, they open it, they deal with it, and done. And then therapy with a spouse partner. I think this can be really effective for people who may have some sort of dyadic pattern going on where one of them procrastinates, the other one nags, and it might not work optimally for them, but they're used to it and it feels fine for them. But if they want to shift that, getting some therapy with a spouse or partner can be nice. And finally, we're moving over to next steps if symptoms remain. So a therapy referral, again, if any of these things need kind of a longer amount of time, the psychoeducation can be easily done, maybe even in the primary care visit. and then following up with that short-term therapist. And then if people are still struggling, refer to a therapist. And I also always want to make sure that people's case management needs are met. This should probably be earlier in the flow diagram, that they have food and housing, so we're not forgetting about those things. And then if needed, moving on to pharmacologic interventions. So this is a difference between the UWASH flow diagram and the one that we put in our paper. And I'll talk more about that a little bit later. But we chose atomoxetine and bupropion as first line medications to offer. Atomoxetine particularly good if there's an anxiety component, and we think it works as a norepinephrine reuptake inhibitor. It does have an FDA indication for ADHD. Bupropion is particularly good for depression. It is off-label for adult ADHD, but often used in primary care. I'm sure you've come across that. Not if there's an eating disorder or seizure risk. And it works as a norepinephrine and dopamine reuptake inhibitor. Clinical side effects might include increased anxiety, episodes of anger, or poor sleep. And if sleep is an issue, using the 12-hour release in the morning can help. I didn't come across literature, but that's clinically what has been helpful for a good chunk of my patients. And if you are considering a stimulant, just remember that they're not ideal for folks who struggle with substance use disorders or bipolar disorder, and particularly not if a patient has a psychotic disorder or a history of psychotic disorder. And we've had a fair number of patients in our clinic who maybe they had some trauma in their lives and may have had some concerns about parasites even before starting stimulant medication, and then started stimulant medications and then really did have trouble with something that might be delusional parasitosis. So that's something I screen for now that I didn't when I started practicing. You also want to check blood pressure, heart rate, weight, cardiac history, family history of structural cardiac disease, urine drug screen, prescription monitoring program. And certainly if those all check out, you can have the patient sign a controlled substance contract. And again, if this is pretty straightforward, I imagine it could be done with a care coordinator and right in the primary care provider setting. So just to review the stimulants that are available, methylphenidate type stimulants block reuptake of catecholamines into presynaptic neurons. And there's the short acting and the long acting. Then there's dexmethylphenidate, which is an enantiomer, twice as potent. So if you're thinking about a patient switching between the two, just keep that in mind. And then the amphetamine class, which promotes release of catecholamines and inhibits reuptake. There's the mixed amphetamine salts, which we saw kind of skyrocket in terms of use over the last 10+ years. And a lot of the advertising was for those. Dextroamphetamine and lisdexamphetamine, which is simply this, dexamphetamine released in the small intestine. Something that I came across that I was unaware of is that urine pH actually changes the elimination half-life. So if your patient's having variable reaction kind of day to day with one of these medications, you could consider asking them about their diet. Unfortunately, a Cochrane review of 19 amphetamine studies showed that they were all low or very low quality. None had low risk of bias, and the mean time studied was about 5 weeks. So not a lot of great data to review with patients in terms of what we know. What we do know is that stimulants have the risk of being neurotoxic. This is from animal studies, that they've been shown to cause neuronal cell death and hippocampal atrophy, and that was in young animals, and then showing hippocampal atrophy as they grew up. We know that they have the risk of mania, of cardiovascular events, and of increased anxiety. And we know that a good chunk of our patients abuse, misuse, or divert these medications, mainly to friends and family, and mainly friends and family use it to improve performance. There is some data about college students using these when they haven't been prescribed to them, and that it doesn't actually long-term improve those people's performance. So just to summarize management strategies, and again, we can talk about kind of where to house these patients at the end. We want to think about, does the patient actually have these symptoms, or are they just thinking that they do? And if they are just thinking that they do, why? And maybe we can treat something more relevant for them. Treating causal disorders and thinking about when the symptoms started and if there's severe impairment in more than one domain. Offering our behavioral interventions, our therapy referral. If the case management needs are not met, how can we meet them? And then moving on over to offering first-line atomoxetine or bupropion. And I think that in reviewing the kind of lack of data with long-term stimulant use and the known risks, that's why we put the atomoxetine and bupropion before the stimulants. And then if you are considering stimulants, helping the patient or the primary care provider to weigh the benefits and risks with the patient, including cardiac risks, monitoring vitals, checking those cardiac function with the family history of cardiac disease, individual history of cardiac disease, checking a urine drug screen, the prescription monitoring program, signing a contract and following that up with random urine drug screens and pill counts, which are a little more challenging when we're practicing remotely, but still doable. And in terms of thinking about integrated care, I think just thinking broadly, we're population psychiatrists. So when the criteria are broadened and more inclusive, we're going to see more patients wondering about this. And we know that there's been increasing stimulant use in adults and that the side effects have perhaps been downplayed or just unknown. So PCPs often face questions about adult ADHD and how might our teams support them. Let me see. And I think that's why we came up with our flow diagram, kind of an idea of first do no harm flow diagram based on the evidence as we read it. So again, the same thing, screening and treating medical diagnoses. I think that can be easily done in collaborative care, screening and treating psychiatric diagnoses in collaborative care. And then if things are more complicated, providing that direct consultation. And then treating adult ADHD in collaborative care, but being available if there's higher complexity for direct consultation. And I think some of that higher complexity will come up in some of the questions where people aren't coming in always asking about the diagnosis, often coming in with the diagnosis, often coming in already on medications. So I have a bunch of cases we can think about in terms of when to assess or treat and how to fit that into the collaborative care model versus direct consultation model. But I'm also eager to hear your questions and eager to have more discussion about this. Yeah.
That's great, Dr. Schlossberg. Several questions. Getting back to functioning, an attendee wrote in and asked about assessing impairment in functioning and while managing expectations. How do you have conversations about this? This is really treatment of a disorder, not performance improvement. How do you talk that over?
Yeah. So I guess it really depends on where they're coming to me. So if someone hasn't kind of gone through this flow diagram and hasn't already had the diagnosis of ADHD, I would certainly kind of start there and make sure we're not missing something. Like maybe they're not performing because they're not getting enough sleep. So I have that conversation just really in a straightforward way with my patients. And then if it gets to the point of, check, nothing else is in the way and they're still having this complaint, I just have that conversation about risks and benefits with my patients about, look, this is where the literature is. I know that this diagnosis is out there. Lots of people are talking about it. And my job is to make sure that whatever treatment we offer you, the benefits are way outweighing the risks or side effects. And I think, being a child psychiatrist as well, I think if someone's in school and they're getting maybe C's, that's kind of easier to quantify than if they're just, in an office and they're fine, but no promotions. So I think it's an ongoing conversation. It's not kind of a black or white answer.
Mm-hmm. Thank you. But I think helpful to consider where on the flow chart is the person entering, and that it informs things. Differences between adult women, adult men, and whether diagnosis was accurate in childhood? Is that a consideration you have?
Absolutely. I mean, I think just in general in our field, you could see in, I think it was 2006, those numbers where mainly adult people with ADHD were Caucasian and male, so who are these diagnoses serving? And so I didn't come across literature, didn't specifically look for literature about differences in male and female adult ADHD. But more often than not, especially in children, females are either missed or eventually diagnosed with inattentive ADHD and feeling kind of underserved by the system that way. So I'm trying to think of my practice and seeing women come in with this question. I think that more often I've actually had women recently come in with a question of, do I have Asperger's syndrome? Or do I have, am I on the spectrum? And there's some kind of overlap in terms of symptoms. And so I think there's some like websites out there kind of educating women around something like that. I don't know if you've come across that as well, but I haven't specifically seen differences in women and men, other than knowing that as a field, we often kind of think about women second. And you can remember from that statistic where the number of scripts for women increased in about that 10-year period by like 300%. So you know that someone's paying attention to that population, I think. But again, clinically, I don't have like any specific examples.
Thank you. Have you ever tried this? Do you have recommendations with pulse dose? Increase doses of stimulants during late luteal phase for women with prominent roughening or increase in symptoms during premenstrual days?
That sounds fascinating, and no, I haven't come across that.
Okay.
But it sounds like someone in the audience has, and I'd love to hear more about that.
One other a question came in about prescribed amphetamine as a treatment. This is outside of ADHD, but kind of harm reduction for individuals with methamphetamine use disorder. Did you come across that? Is that something you've seen in practice? Is that, yeah.
Great question. In terms of using these for harm reduction, that's not something that we commonly do in our practice. And I can't say that I came across the literature in preparing for this talk for that. So I don't want to speak to that, not having as much experience with it. Okay.
When do you stop a stimulant? How do you do that? So someone writes in and says, if someone, what if a person says, I don't want to stop, I get more done?
Yeah. So I actually have a few examples of cases where we might consider stopping a stimulant. So I can kind of talk about that in terms of one of these cases. Let me find it. Okay. So here's a woman in her early 60s. She's a married Thai American woman, prescribed lisdexamfetamine for many years, recently met with a care coordinator because of increasing PHQ-9 over the last few months, and now it indicates severe depression. She does have suicidal ideation, but no intention. And she's been a successful businesswoman for many years. However, now she's crying daily, she's complaining of poor sleep, and she's on lisdexamfetamine 50 milligrams daily. So again, these are all composite cases, but I have worked with a good number of people who have decided with me to stop their stimulant medication. And it's always easier if we decide together, and if they're having some symptoms that might be side effects of the medication, to stop it. And it's always nicer to stop it that way as well. I've also, not been able to, in good faith, kind of continue a stimulant medication if someone, maybe their pulse was elevated or persistently, or trying to think of other examples. Maybe they started having more psychotic symptoms. And in that case, you just kind of have to have that conversation with the patient and not advise continuing the stimulant. So for a patient like this, I think having a frank conversation about the risk-benefit ratio of continuing this medication versus stopping the medication, and then offering other alternative approaches to her symptoms for example, if you go back to the flow diagram, kind of the organizational skills training, or, if she's continuing to have crying daily after you stop the medication, after she's sleeping better, continuing to have a higher PHQ-9, then, making sure she has a therapist, and maybe even kind of ongoing support in a support group based on kind of her specific complaints at that point. And certainly kind of keeping an eye on that suicidal ideation piece. So for this example, I think it would be pretty easy to kind of weigh the risks and benefits and talk about maybe a trial off of this medication. And for someone else, I'm sorry, there was another example in that question. Can you tell me?
Yeah, the example in the question was more along the lines of a person retiring and someone saying, "I get more done with this. I don't want to stop it."
So they were retiring from their job?
From work, yes.
From work. Okay, gotcha. Well, I mean, I think if you go back to the criteria, in 2 or more settings, so I don't know what the second setting would be after you retire, but certainly having a history of that medication being useful and having, legitimately met criteria for adult ADHD in 2 settings previously, I think that would be just a conversation to say, you did meet criteria. It is, standard practice to continue this if you meet criteria here, and then also just lay out the risks and benefits as someone gets older of continuing any medication, really.
So continuing care, but changing treatment possibly.
Laying it out with the patient. Yeah.
It gets to another set of questions that came in earlier about what's reasonable to expect an improvement in with a stimulant treatment versus like a group CBT for executive functioning improvements. Like what can we expect?
Where's that level? Yeah, for kids, we have a really nice rating scale of the Vanderbilt, right? So we give a Vanderbilt screener for kids to school and to home and see if the patient is improving. I think the ASRS could be used as that to see if the symptoms are improving. So that might be a really nice use of that. And then, or just identifying with the patient the target symptoms and, targeting to treat with those symptoms.
Mm-hmm. And what someone asked specifically if medications help most with inattention and focus, but that executive dysfunctioning, difficulty planning, et cetera, is best managed with skills groups. Is that accurate? Is that what you've seen? Is that what the literature suggests? Yeah.
I'm sorry, say the first part of that question.
With stimulants mostly helping with inattention and focus, and that executive dysfunction rather, actually not improving with stimulants.
Interesting. Yes, actually, stimulants alone won't help someone learn how to manage their time. So that's a really good point. And actually pairing stimulants with those first line treatments that we recommend will, give people ultimately more benefit. So I definitely recommend pairing them.
A very specific question about atomoxetine. What's your experience with tolerability and side effects?
Yes. Yes, I have. Oftentimes people complain of nausea when we start that medication. So there's a recommendation of starting it at 40 milligrams for 3 days and then increasing to 80 milligrams. And I think that's because it takes it a while to kick in, and you don't want this very slow up titration where someone might not get benefit from it. But clinically, I often have to slow that way down because of initial nausea. Yeah. I don't know what other people's experience with that medication is. I find that like for people who it works really well, but it doesn't work for many people.
Someone wrote in earlier when you were talking about apps. Can you say a little bit more about productivity apps? Give an example. Yeah, that question came up when I was talking to primary care providers as well. And because I couldn't find like a review paper on like, these are the best ones, or this is what to look for, I didn't want to endorse any specific productivity app. And so then someone in their group just told them the ones that they recommend. So, okay. So I don't want to kind of, And I guess just to clarify, productivity meaning like accomplishing tasks in life, like that's what it's related to?
Right, right. Or even using kind of the alarm function on your phone, like that could also be a productivity app, giving yourself 5 minutes to do X and then the alarm goes off and then it kind of refocuses you. So a lot of ways to go about using apps to help with ADHD symptoms. And the ADHD coaches are, I would say, more expert at kind of walking people through those and making sure they're following through with those. Yeah.
Okay. I'm aware of the time. There are a couple other things. There's, it's about 3 minutes.
Sure.
Or is there another case you wanted to be sure to walk through?
No, I actually find like, talking about people's questions more interesting than kind of walking through a presentation. So.
Okay. Well, great. Thank you for this. Yeah. What about this? So it may take 3 months for atomoxetine to have an effect, unlike a stimulant, which might be after getting the target dose. How do you manage that? Do people
3 months? Yeah. Yeah, and again, you'd have to think about, the specifics and kind of maybe even offer the patient options. If you felt comfortable that they would be a good candidate for a stimulant medication, you could say, look, we can try this. It works for most people. Long-term, we don't know. Long-term, this is what we know in animals. Or you could try this other medication. It'll take a little while to kick in, but less side effect profile. So I would, if it's an appropriate patient who, doesn't have risks for other options, sometimes I'll lay them all out there as well. And then planning, similarly in kids, you want to plan for that time when the atomoxetine is maybe starting to kick in. So you want to make sure that they have a lot more scaffolding during that time for the things that are getting in the way. And so for adults, that might look like talking to a boss at work and decreasing the workload for that amount of time, or taking extra things off their plate.
You've mentioned there are other questions, but this just strikes. You have a distinct practice in children and adults, and does it go better? Is it easier to see children with ADHD than to confront consultations in adults?
Yeah, I mean, I would say that diagnosis has been around a lot longer for children, and originally maybe it was created for children and then maybe expanded to adult ADHD. And so I think that the protocols and the collateral are a little bit more straightforward for kids, and it's a little bit less of a kind of a muddy diagnosis, like what's productivity at work versus at school. At school, you get grades. At work, it's like, well, do you get fired, or do you get a promotion, or do you just kind of get by? So it's a little, just based on kind of the lives of children and adults and how the diagnosis is framed in terms of kind of ability to accomplish things. It's much easier to understand, if a child is accomplishing things or versus an adult. And that collateral piece, I think, is really important for adult ADHD. It's just much harder. Practically, I've seen adults either come in with, you can't get the collateral, or they come in and whoever they bring in just agrees with them. That's kind of what I see. So.
Okay.
Yeah.
All right. We just a minute. I'm going to see how many more questions I can fit. Did you come across long-term neuropsychological data from kids or children or adults that support the kind of concerns you had described from other species? Is that data in humans?
I haven't seen that data in humans. I wish I had. Yeah.
And maybe the last one. A DBT therapist clinician wrote in saying that women with impulsivities, sometimes diagnosed with borderline personality disorder, maybe ADHD might be a more likely explanation. Do you see that distinction, or do you see that not distinction, but do you see that as a diagnostic dilemma at times?
Oh, I see that overlap a lot. And the way I think about diagnoses, you can let me know if this makes sense for you folks as well. But the way I think about diagnoses is, if they're meeting criteria, what's the most helpful tool right now? It's a tool for you. It's not like a label to wear forever. And so if you use that tool, the diagnosis as a tool, and then you use the treatment options as tools, and that helps the person, then maybe it's the adult ADHD that's a better fit for that woman, versus if maybe they don't meet criteria for adult ADHD, it's just a question, or maybe the borderline personality is a better tool for them right now. And then I would go with that again, if they're meeting criteria. I'm always looking for the umbrella diagnosis that's causing kind of the trickle down symptoms. So.
Okay. Well, great, Dr. Spotswood, just due to time, we've got to stop, but clearly a high level of interest. Thank you for presenting in our Grand Round series today. And thank you to our participants for listening and for writing in with questions. So we'll end for now. Dr. Spotswood, do you have, I wanted to test out just like sticking around for about 2 or so minutes. Does that work for you?
Yeah, thank you so much for having me. It's been a pleasure.